गुरुवारे रस्ता करावा.
मैम, मोनिका मैम.
So
Ma'am, we are live now.
let us start, sir.
Yes,
Alpesh sir is joining. A very good evening to all the esteemed faculty members and the delegates who have joined us in the ECHO webinar series, which is Enhancing Care for Healthy. These are focused webinars which have been introduced for obstetrician and gynecologists by none other than the program director, Dr. Kalyan Varambe, sir. This theme for today is AUB and management. And therefore, we will be having Dr. Neeta Thakre, madam, who will be speaking on non-hormonal treatment and followed by a panel discussion. Let us begin with the blessings of Lord Almighty. Can we have the inauguration slide, the tech team, please? Yeah. There is no. Thank you. Now I take privilege to introduce our program director, Dr. Kalyan Barande, sir. Today, he is the past president of IAGE, the past chairperson of the Public Awareness Committee, FOXY, an executive member of various organizations, including ISAR, MSR, and he is also the Maharashtra State Vice President of the IMA. He's received the Champion of the Foxy Award, the Legends of Gynecology Awards, and the V First Tree Award by the Governor of Maharashtra. Sir also has been the past president of the Latur Obgyn Society and chairperson of Infertility Committee at AMOX. Sir, it is a proud privilege to coordinate this webinar for you as the 16th episode. We welcome you today for your welcome address.
Thank you, Dr. Monica, for such a nice introduction. Good evening. It's my great pleasure to extend my warm welcome to all our distinguished faculty members and delegates to this ECO webinar series being conducted in collaboration with West Zone Foxy Societies. I take this opportunity to convey my sincere appreciation and gratitude to our chief guest of honor, esteemed chairperson, respected speakers, and our distinct panelists for graciously accepting our invitation and taking time out of their demanding schedule to contribute to this academic program. Your presence and expertise add immense value to such scientific deliberation. We are also delighted to welcome colleagues and delegates joining us from across the region. Today's program includes a discussion on DUB, or preferably now is called AUB. I am confident that the academic exchange this evening will be highly enriching and will contribute meaningfully to our continuing learning and clinical practice. Once again, I extend a very warm welcome to everyone for joining for this webinar. I welcome Dr. Alpesh sir, Dr. Parul sir, and Dr. Mahesh sir for joining for this webinar. Over to Dr. Monica.
Thank you, sir. It is our proud privilege to introduce our chief guest for today. Dr. Alpesh Gandhi, sir, has been the past president of FOXY. Sir has been instrumental in establishments of ICUs and HDUs across. He's also been instrumental in formulating many GCPRs and the Foxy guidelines on pregnancy with COVID-19. Sir took over the reins of Foxy when COVID was very active, and we have seen his true leadership, and that even with when physical meetings were not allowed, sir has already kept the momentum going, sir. So we welcome you as the chief guest for today's webinar, and we request you for your words of lessons.
I have a very good memory about Dr. Alpesh sir when I was a chairperson of Public Awareness Committee. He was the one who has taken only one webinar in Foxy history about the Down survivors, their parents, and this was such a memorizing webinar where there were many Downs babies who came online, their parents and their teachers came online, and it was really insightful to have a thought of taking such good webinar. Thank you so much, sir. Over to Dr. Alpesh, sir.
Thank you, Dr. Kalyan and Monica.
Thank you, sir.
Thank you for your constant reminding and sharing the link and all the efforts. Kalyan, it was wonderful days where we have worked together for Foxy, for women's healthcare. I would like to congratulate all of you for continuing this Eco Web series, webinar series, and continuing good academic work. Today's topic is very, very important. AUB, very frequently we come across patients of AUB, and there are so many myths, misbeliefs, and there are so many regular updates in the management of AUB. So it's good that we regularly update our knowledge about AUB. It is the bleeding responsible for significant health problems and social embarrassment, and it is one of the common reasons women seek healthcare. It has a significant impact on the quality of life for women. And India, the reported prevalence of AUB is around 17 to 18%, and AUB leads to loss of productivity and may result in surgical interventions also. Heavy menstrual blood loss, which interferes with the women's physical, emotional, social, and marital quality of life, and which can occur alone or in combination with either with other symptoms or other diseases. Removal of myths and misbeliefs are very, very important, and proper counseling, offering all the alternate options, surveys of trends and effects of hysterectomies, after hysterectomies, auditing of hysterectomies, all are very, very important. So I am happy to see that you have taken this very important topic for today's webinar. And I am also thankful to all of you for giving me this opportunity to meet many of my friends during in this webinar. My regards, hello to Dr. M.C. Patel, Dr. Parul Kotadawala, Dr. Neeta Thakre, and so many other eminent faculties. I wish grand success to this webinar, and I wish my best wishes to Dr. Kalyan for his all future endeavors. I know I have seen him working very hard and is very with passion. During those days also, I think I do not remember the exact number, but I think must be more than 25 workshops on AUB during 1920 during 2020 and 21. So good luck, Dr. Kalyan, and best wishes for the success of this webinar. Once again, thank you very much.
Thank you, sir. It is always an honor to have you on the same platform and to be sharing this. It is an honor for all of us as juniors. So, Kalyan sir, can we move ahead?
I think he's
Yeah.
Nat,
Uh,
okay, go.
Yeah. So I take the privilege in introducing our guest of honors for today, Dr. MC Patel, sir. Sir has been the past vice president of Foxy. Sir has also been the past president of the Ahmedabad Obituary Society, the IMA Ahmedabad, the NMO, and sir is an important medical legal consultant across India. Sir is also very active in social service and he has been operating in the Northeastern districts since the last 23 years. Sir, Sir's passion for teaching continues in the last 3 years. We have seen all throughout since the time of COVID. Sir, it is an honor to have you with us today, and we wish all the very best for your future endeavors too. So over to you for your words of
Dr.
wisdom.
Monica MC Patel is a great academician and he
Yes.
conducted nearly more than 300 happy learning webinars. And he has reached
I
to
have
each
been a
and
part of
every
more than
corner.
We are all part of
150.
that.
I know that.
Yeah,
I
so
know
more
that.
than
But
Patel
150.
sir has
I
joined. I
want
suppose
to
Patel sir has
inform
joined.
the exact number, more than 300. I know you all are.
Was that 235 around? We are
Yeah.
still short of 250. We are
Okay.
around 235.
Yeah.
And we are
You
a
all have
constant
reached
part with
each and
sir.
every corner of India. Great
So,
work.
Patel sir, over to you, please.
Oh, yes, because I have to shift
Yes,
to
sir.
one more webinar and my own lecture is there. So I'll be. So congratulations, Dr. Kalyan, for this series. And thank you for inviting me to be guest of honor to bless this webinar. And have seen you working in Foxy since years together. And as far as today's topic is concerned, AUB, very common ailments for any woman, irrespective of age, from puberty to menopause and even postmenopausal also. So it is a very pertinent topic to discuss in today's era. And you have chosen all the learned speakers for the same. And I hope this webinar to be a grand success. And I also wish you for your endeavor in Foxy as a Vice President Foxy. And I hope we both work together in Foxy in year 2028. Thank you. Thank you
Wish
very
you all
much.
the best, sir. We are with you, sir.
Thank you. Thank you. Thank you.
Thank you, sir, for joining us today. And now it is my privilege to introduce Dr. Parul Kotlavara, sir. Sir is the professor and head at the Sai Institute of Medical Sciences, Ahmedabad. Sir is also the chairperson of the ICOG, the vice president of ISOPAC, chairperson of the education committee of the AOFOG, the India coordinator for New European Surgical Academy, the India coordinator for International Adhesion Society, the vice president of Foxy in 2006, and president of SOGOG in 2009. Thank you, sir, for joining us today, and we request you for your words of wisdom.
Well, thank you so much for kind words and asking me to be part of this important webinar. Dr. Kalyan has been always super active. Hello, am I audible?
Yes, sir.
Yes, sir.
And I wish him all the best for his future endeavors. And I compliment him for picking up this very important topic. AUB is always, in fact, more than. Sorry, somebody is speaking.
Please mute
Mudita ma'am,
everyone.
please mute yourself.
So, two Monica's, one with C and one with K. Thank you so much. And I see so many friends from my own society, Dr. Alpesh, Dr. MC, stalwarts, Neeta, Parth, Munjal. I also see very strong panel also, including my society colleague, Dr. Mahesh Gupta. Sorry, he's now in Gandhinagar Society, but he still lives in Ahmedabad. Then Archana and all other panelists and experts. So I wish you all the very best for excellent webinar. I would not keep on repeating the words which my colleagues have already spoken. Thank you so much for asking me to be part of this. Thank you.
Hello.
Thank you, sir, for being a guiding force to all of us in Foxy as well as ICOG and even IAG also. Thank you so much.
Thank you, Alpesh sir, Patel sir, and Parul sir for joining us today and gracing the inauguration. Sir, with your permission, can we declare that the inauguration is over?
Yes, yes, please.
Yes, sir. Sir,
Please go ahead.
but with one request to all the Gujarat societies to please nominate Dr. Kalyan Barande sir as a candidate for the West Zone Vice President Foxy.
Thank you so much, ma'am.
Yes, sir. Yes. And I now request Dr. Monica Gupta
In advance,
madam, to please introduce
congratulations.
the
Thank you, sir.
Yes.
Kalyan is a very apt candidate, so I wish him all the best.
Thank you, sir.
So, Monica madam, we can start with the panel discussion. Tech team, can you start with the panel slides, please, first? Yes, thank you.
Thank you, Kalyan sir, for making me the part of Eco webinar. And that is a big success. And in this, we have a very nice panel every time. And today we are going to discuss AUB. And our moderator is none other than Kalyan sir, who is a program director of this program. And our experts are Mahesh Gupta sir and Dr. Archana Dwivedi. We all know sir is a president of IAGE. And
That's fine. My introduction is over, madam.
Sir, you are doing a wonderful job as a president over there, and as a vice president, you will definitely do wonders in the Foxy also.
Thank you, ma'am. Please give me opportunity.
Dr. Mahesh Gupta, sir, is an expert in our panel, and he has received 2 medals in 1983 from Gujarat University for Surgery and Medicine Department, though he is working more on the PPH. But still, he is expert in all the fields, and he has received Times of India Health Icon Award in Ahmedabad and received late Dr. Piyush Patel Award by IMA. Welcome, sir, to the webinar. Next, Dr. Archana Dwivedi. She is a chairperson of Midlife Committee and national chairperson of IMS website Committee 2325, and she was the president of BOGS, and she's a founder president of MSV in 1920. She's a secretary of WDW-IMA for 2020 to 22. And she is working in Vadodara for last 20 years. And she will be joining soon with us. Welcome you, ma'am. Next. Our extreme panelists are Dr. Naman Agarwal. He is an assistant professor at Jaidus Medical College, Dahod, Gujarat. And he has done more than 800 laparoscopic surgeries. And he is expert in total TLH and laparoscopic myomectomy and so many laparoscopic surgery. Welcome you, sir. Next, Dr. Deepika Singhvi. She is a fellow in fetal medicine and ex-secretary of VOGS in 25-26. Dr. Akash Gujjar. He is a fertility consultant, endoscopic surgeon, embryologist working for last 18 years in Navarsi, and he has participated in many state, national and international conferences, and he is an invited faculty at ASHRAE and Suffolk. Welcome you, sir. Dr. Chintan Thakkar, sir, he's working in the Mother Care Hospital, Bharuch, and he's a past president of SOGOG and past president of the Bharuch OBGY Society and even the IMA branch of Bharuch. Welcome you, sir. Next. Dr. Mudita Jain Talesra, ma'am. She is a master in reconstructive and cosmetic gynecology, and he's a master trainer of CAC, and she's a treasurer of VP Con Bhopal in 2024. Welcome you, ma'am. Dr. Devraj, sir. He is trained into the IVF and Advanced Laparoscopic Center, and he is doing IVF practice in Junagadh for last 7 years. Welcome you, sir. And over to Kalyan sir for the panel discussion.
Thank you.
Archana ma'am has joined.
Yes, thank you, Dr. Monica Gupta madam, for this introduction. All our panelists are going to be giving their expert opinion about AUB. We are going to have a panel where all the questions will be asked to everyone. Whoever wants to answer these questions can take these questions. And thank you, Dr. Monica, madam, for taking this ahead. So AUB is a broad term that describes irregularities in the menstrual cycle involving frequency, regularity, duration, and volume of flow outside the pregnancy. AUB impacts up to 1/3 of the women in some time of their life. The impact of AUB on quality of life is very important. 60% of the women with HMB, heavy menstrual bleeding, hysterectomy within 5 years from the diagnosis in the rural era. That is the reason we have to talk about AUB more, because anxiety, decreased work productivity, iron deficiency, anemia, discomfort, and impact on relationship. This has been proven by many randomized clinical trials, which have been proven beyond doubt that in the rural area, the patient might go for a hysterectomy, which we want to prevent. As everybody knows, this is a palm coin classification, where palm is P is for polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia. And coin is coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not yet defined. So structural and non-structural causes. So now coming to Dr. Naman Agrawal.
Yes, sir. Good evening, sir.
Good evening. So can you just describe about the components of palm coin and how FIGO has classified this classification?
Hello. Good evening, sir.
Yes, sir.
Sir, recently in Zydus Medical College ECAL project, which is under you, sir, it was done in Zydus Medical College, sir. Thank you for the project, sir.
Yes, sir. Thank you.
Sir, according to the answering your question, the FIGO classification, abnormal uterine bleeding, there are structural causes and non-structural causes. Sir, structural causes include, sir, palm, polyps, which may be endometrial or cervical, adenomyosis, leiomyoma, and malignancy. And sir, there are coagulopathy, ovulatory dysfunction, endometrial causes, and iatrogenic, sir.
So these are the structural, and others are entities not defining by imaging or even histopathological diagnosis. Maybe
Yes,
not there. For these are
Yes,
the causes which we need to discuss. So how are you going to do a proper diagnosis and how you are going to evaluate AUB, Dr. Naman?
Sir, first of all, when the patient comes, we right through seeing the patient, we can start to diagnose the case. If the first we see what is the age of the patient, right from the time the patient is entering our OPD, then we are taking down, asking the history. In history part, sir, we first of all we have to categorize the patient. Is he having AUB or not? Sir, the definition which you gave earlier, that the patient the means the cycle length is short, means, and the volume is more, menorrhagia or polymenorrhea, we have to diagnose it. And the first investigation which we do for all the patient in case of AUB is urine pregnancy test, sir. That is mandatory. Then we, sir, take the history and move further, sir.
So what is the main important part in history and examination you think is important in these patients?
Yes, sir. In history part, sir, first of all, that means what is the length of the cycle, and when the menses come, then how many days the menses continues, and each day how much pad she is using. So that are the more important parts in the history taking according to the gynec side. Probably she may have a coagulopathic disorder, so the bleeding from other sides. Yeah, the history of that is also important. And in the examination part, sir, we have to see all the causes, right, starting from vulva, vagina, cervix, and then the uterus. The examination, the size of the uterus, and or she is having any structural abnormality, fibroid.
Very rightly said, it is recommended to obtain a thorough history and to conduct a physical examination to direct the need for further investigations and treatment, that is grade A evidence. It is recommended to obtain information about the concomitant use of any medication which may likely cause AUB. And in patient with AUB, any of the following criteria like history of bleeding starting at menarche, that is very important, and whether there is a postpartum hemorrhage, surgery related to any bleeding, bleeding associated with dental clinic, all these frequent gum bleeding, this history might get you to the causes of AUB per se. Dr. Deepika, how you are going to evaluate these patients? What investigation you are going to do for these patients?
Okay. Hello, sir. Good evening. Good
Yes,
evening.
ma'am.
Yes. So first, we, of course, as you told, we will take a detailed history of the patient regarding her menstrual cycle and all. Other any bleeding episodes are there or not? Detailed examination, including per speculum and per vaginal examination. And then needed, the first important will be, because in a reproductive age, urine pregnancy test is very important to rule out it. It's not related to obstetric cause. And then a sonography, detailed sonography of the patient, which helps us to rule out the many causes, whether it's a structural or non-structural AUB. And for non-structural AUB, if it is there, then we have to evaluate her hemoglobin to see her overall clinical status, her PT, APTT, liver profile, that's all. And if needed, like if you sonography suggests it's a thick endometrial hyperplasia, if it's there, then we should advise a biopsy also, endometrial biopsy, if it is more than 12 on sonography.
Okay, very rightly said. You need to evaluate a WBC count. Then you consider a ferritin measurement if required. Then
Yes.
PTTK and all these tests. As far as possible, do a transvaginal sonography, being a
Yes.
gynecologist.
Yes.
And in case where there is a difficulty in diagnosis between fibroid and adenomyosis, you can advise an MRI. And those
Right.
cases where evaluation of endometrial cavity with the presence of polyp and something, you can ahead go for a hysteroscopy. Mind you, in the today's era, endometrial sampling is very important, and that can be done on OPD basis. And where coagulation disorders are concerned, you need to do all these specialized tests will come in the next patients. So now coming to Dr. Akash Gajjar sir. Case 1, 14-year-old girl comes to OPD with symptoms of heavy but painless vaginal bleeding. This is the first time that she has had these symptoms. Her menarche was at 11 years. How you are going to proceed? Anything important in history which is missing? And what investigations you are supposed to do for this patient? Dr. Akash,
Yes,
sir.
yeah, good evening, sir.
Good
Sir,
evening.
this may be the case of underlying coagulation disorder because may be manifested first time with heavy menstrual bleeding. Second number, initial duration, initial cycles when patient has started menarche, the initial cycles may be irregular. So we have to take into account also the history part, like the cycle pattern, duration of the cycles, how many days the cycle is there, how many days the cycle is remaining, and as far as the counseling part is also concerned, that we have to investigate this patient for blood investigation in the form of complete blood count with platelet count. And if we suspect the underlying coagulopathy, then we have to investigate for the coagulopathy. And important history regarding the other bleeding sites disorder like gum bleeding or any other sites of bleeding. And thyroid profile, underlying hypothyroidism may be there, and ultrasound abdominal scan for any pathology, and that's part of the investigation, sir.
Okay, what is the differential diagnosis in such young girls? What you are thinking of, any structural or non-structural causes?
Maybe, sir, physiological or non-structural causes, because initial cycles may be irregular. That's why.
Yes, sir. Very rightly said. A coin, we are thinking of coin here. And other causes were rarely vulvovaginitis, some sexual abuse or trauma, or some foreign body might have caused this. Now coming to Dr. Chintan Thakkar, sir. What
Yes,
is
sir.
the treatment option for such young girls, sir?
Sir, I would like to check her hemoglobin level, and I would, from the history, I would like to assess that actual whether she is having actually more bleeding, or she just she just feels like she is having more bleeding. And if if she is hemodynamically normal, the hemoglobin level are normal, then I would just give her supportive medicines like some tranexamic acid, and mostly reassurance. As far as the sonography is normal, I would try to explain the anxious parents that this is her rhythm of periods, that is her HPO axis is getting mature, so this may take 1 or 2 years, and during this time, we have to just support her and reassure her. And at the most,
So you are going to
during
reassure by telling them that it's some immaturity of the hypothalamo-pituitary ovarian axis. That's what is important.
right, sir. And we can keep her giving iron calcium tablets, so that her hemoglobin level doesn't fall with this occasional menorrhagia parts, and that's it.
So
No,
Chintan sir, she
no
comes
further
back after
hormonal
2
treatment.
days after your counseling and she says, Doctor, abhi bhi bleeding ho raha hai. It's not reduced yet. So any medication you want to give to her?
Right, sir. That's that's an irony part that we many a times we come across that in spite of this routine measures, it doesn't stop. Then as a last measure, I can start progesterone. Usually, it shouldn't be required. So I would be slightly less eager to start. But okay, if she is bleeding heavily, amounting to the hemoglobin, decreasing the hemoglobin level, I may start progesterone to her.
Sir, in my OPD, 80% of the patient will come to me with either taking pause tablet or Tranexar tablet or some Silate tablet, ethamsilate. How do you counsel these girls now?
Uh, so it's like it's better to take this sort of medicines under a medical guidance, so that the exact dose can be provided. And it is better that we do a sonography and rule out the structural causes, which very occasionally we can come across in this sort of young patients. And it is better to start this sort of medicines under a strict medical supervision only.
Okay, Dr. Mudita, what is your view about starting tranexamic acid or ethamsilate for these girls?
Sir, I think tranexamic acid and ethamsilate is very good to start with these girls, because instead of giving them trouble of having heavy menses, because they are very young girls, 13,
So,
14
so
year
after
olds.
3 days you start, or after 5 days or 7 days? What is your
So after
deadline?
third day only. If her previous cycles are also very heavy, then I can start on day 2 or day 3, if she prefers that she is having heavy menses on day 2 or day 3. Then we can start. In fact, we can start with 1000 gram or 1500 grams also.
Okay, so that is
500 BD and 500
that is a whole
TDS.
day dose of
Whole
500.
day dose of medications.
So
Instead of
she,
taking her on hormonal pills, it's better to give
right.
antifibrinolytic drugs.
So first line is antifibrillary counseling. She
Yes, sir.
still comes back to you after 3 days that no bleeding is, she's passing 2 to 3 pads per day and there are some clots now.
Sir, first of all, I think if the child is coming to you back to back, we ask mother to store her pads, whether she is exactly complaining what she is
Yeah, whether
speaking, and we can
her
see
pads
we
are
her.
completely soaked
Yes,
or not.
yes. Instead of show some OCDs, she's actually bleeding like that. And if we see yes, she's really having high menses or high menorrhagia is there, then we can add on a progesterone definitely.
So which
But
progesterone you prefer, madam?
Sir, now I had shifted to dydrogesterone, and they are giving very good result instead of having this levonorgestrel pills.
You are using,
It's very contradictory things that we had shifted over these drugs.
No, that's fine. But what is the dose you are using, madam?
Sir, I am using 20 milligram 1 HS.
Okay, so 20 milligram, you feel the patients are getting comfortable.
Yes, yes. And compliance is good.
Okay, so ideally, medroxyprogesterone acetate 10 milligram
Yes,
BD
honestly,
will
yes, we can use
suffice your
that.
problem. But only problem is once she stops it, she's going to have a withdrawal bleeding again. So that is all.
Withdrawal bleeding can be again heavy, sir. So whenever we provide progesterone, then during withdrawal we again add fibrinolytic, antifibrinolytic drugs.
Now I'm here. I want to interrupt you, Dr. Mudita ma'am, and going to our expert, Dr. Mahesh Gupta sir. You have started your clinical practice, I say 35 to 40 years back. There were no drugs like fancy drugs like this. What is your say about using OC pills for the patients where bleeding was not stopped with the progesterone, sir? Dr. Mahesh Gupta sir. Dr. Mahesh sir is there? Okay, now go to the another expert, Dr. Archana Dwivedi, madam.
Thank you, Dr. Kalyan, for
Yes,
making
ma'am.
me a part of this very important problem many
Topic,
of us face when the patients come at this age. What to do? That is a very important question. Now, I agree with Mudita that tranexamic acid would be a good choice, but if she's continued to bleeding, cost-effective medroxyprogesterone still works. I usually prefer giving TDS for 5 days, then BD or OD depending on that. But yes, I cannot contradict that dydrogesterone 30 milligram SR would be a good dose once OD, then that can be switched over to 20. Coming back to if she's not responsive to progesterone, long back we had estrogen options to be given to the patient. Some books mention estrogen drip also, Premarin drip, which I have never used in my clinical practice probably. Ancient times it was used. But there is one situation where if the progesterone is not working, we have to supplement the patient with estrogen. That is a fact. Otherwise, the bleeding is not going to stop. Preferably, all the other causes have been ruled out. So OCPs can be given. Only thing which clicks in our mind is that closer epiphyseal, this thing, and height issues and all. But believe me, even if the patient attains puberty 2 to 3 years, the height still is going to rise, and epiphyseal fusion takes some time. So comfortably give OCP in patients because we want the bleeding to stop, her quality of life to be not compromised. So I think giving one dose of OCP cycle can be a good enough, fair enough with good estrogens and low dose estrogen pills which are available.
Very rightly said by our expert, Dr. Archana. In case where it is not responsive to progesterone, you can go for OC pill. When I was doing a residency in 1999 to 2004, we used to give one tablet BD and then tapering doses we used to give. But nowadays there are better progesterones which OC pills might not be required, and there is a myth that premature closure of the because of the OC pill that is not going to be there. And now coming to Dr. Naman Agrawal, you have tried everything and consider this patient is 11 years. This is the first cycle she's bleeding. So what comes to your mind about the coagulation disorder, Dr. Naman?
Kalyan, may I
Yes,
interject?
yes, please.
Parul here.
Yes, sir.
See,
You are there. Thank you, sir. Yeah.
I'm still here, but I'm leaving just one comment on this. That
Yes,
when we want to control menses, we should not use the low dose of oral contraceptives.
Right,
I
sir.
personally prefer a higher dose to control menses quickly. Subsequently, you can switch to longer therapy, but otherwise 50 microgram of estrogen overall G is there, which will work very quickly.
Yes, sir. So
So
our
that
time,
is
I was
just
talking about the residency where only oral G was available. Now oral L has come. So we used
so
to give it
lower
sometime one
dose
tablet
is
TDS or to start with. So what is
lower
your view
dose
about?
is good for long-term therapy, for
Right.
family planning, but for menstrual control, I personally believe that higher estrogen quickly works and you achieve your thing. Well, I'll leave the webinar. It is very interesting, and I wish you all the best, you and Dr. MC Patel. Thank you
Thank
so
you.
much for
Thank you,
accepting.
Parul sir. Thank you so much, sir.
Chalo,
Yeah.
bye.
So now coming to Dr. Naman Agrawal.
Yes.
So
Good evening.
now we are thinking of first cycle, heavy bleeding, not controlled for 8 to 10 days. What coagulation disorder you are thinking, Dr. Naman?
Sir, sir, till now, I have not come across any patient, sir, till now, of having coagulation disorder. Means leading to menorrhagia in a young girl. Basically, if mainly they have problem of ovulation dysfunction because the HPO axis is not maintained, and सर जनरल वैसे सर मेरे को लगता है कि मतलब ITP can be a cause in acquired and in inherited hemophilias. They may be a cause, sir.
Okay, Dr. Deepika Singhvi, madam.
Yes, ma'am.
Yes, ma'am. What do you think of how do we going to go manage this patient with suspected coagulation disorders?
So as you told, it's a first cycle of her and it's a heavy bleeding. So yes, there is a possibility of coagulation disorder. Most commonly, it could be a low platelets, thrombocytopenia, or inherited hemophilias can be there. So we have to go for the
And very important is drug-induced heparin, aspirin, some history of DVT or something.
Right.
The patient is on warfarin, right?
Yes, sir. Yes, sir.
Yes, ma'am.
So,
yes, Deepika, how are you going to evaluate this patient history-wise and everything?
So if it is like low platelets, then we have to ask in a history, like, is there any gum bleeding or petechia kind of thing? And any past episodes of bleeding from another source origin. And then we should go for investigations like the complete blood count, which helps to rule out as thrombocytopenia, and if needed, then von Willebrand and PTA-PTT, so that we can reach to the diagnosis.
And those cases where positive screen for coagulopathies, these are very rare, where you can think of referring to hematologists for von Willebrand's, VWB, ristocin cofactor activity and factor VIII activity, right?
Yes.
So how are you going to manage this patient temporarily? All these patients need tranexamic acid, NSAIDs in initial phase. Antifibrinolytic agents significantly reduce their menstrual blood. And in systemic reviews of 12 studies, where more than 700 patients has been used, where there is a 34 to 56% bleeding is decreased with more than 3 milligram of tranexamic acid for 5 days. And these studies have shown that tranexamic acid has superior action. Cyclical progesterone like oral MPA can be helpful. Those patients where they are not to be given estrogen, then norethistron can be given for these patients. And lastly, everybody has said about the combined OC pill can decrease bleeding by 50%. It comes with ethinyl estradiol 30 microgram or levonorgestrel 150 microgram. And the FOXY GCPR guideline says progesterone good with anovulation due to lack of progesterone. Acute treatment is 5 to 10 milligram for 21 days. Prophylactic is for 7 to 10 days per month. That is starting from day 15 to day 25, like that. Combined OC pill are good. And these are some studies of giving intravenous IV injection, giving iron-rich feed, vitamin C-rich foods for these girls. Now, coming to Dr. Archana Dwivedi, our expert, can you just enumerate, madam, about how to do a proper management of a young girl with AUB, madam? Dr. Archana is there?
Yes, I'm here.
Yes,
Kalyan,
ma'am.
just this case you want me to tell 21-year-old?
Yes, ma'am. No. First case, ma'am. We are just summarizing the last case, ma'am.
Okay. So if the girl is 14 years, she comes to you. First of all, I think rule out the other causes, the local causes, as you very well said. Examination should never be denied. Keep her relatives standing with her. If you have ruled out the causes which are apparently their local causes, go for ultrasound scan, find out any reason. Simultaneously, you administer tranexamic acid. As we discussed in the, like, you can give 1 gram, even 1500 grams can be given loading dose, and then tapering dose. If the bleeding is controlled, reassurance and follow up. If the bleeding doesn't control, yes, there's an option of giving progesterones. If progesterones are not working, we can give high dose estrogens or low dose estrogen pills, whatever works for our patient. But she also needs to be supplemented with proper hematinics because of the blood loss. I think that should grossly suffice the picture over there. And regarding the hemoglobinopathies, that is one important chapter which is on increase. Actually, I would say now in tertiary care center, we do find patients who are really detected early. So hemophilias, ITPs, this is the right time to screen the patient for thalassemia and sickle cell as well. So never miss the opportunity to screen this HPLC, I would say. Frankly, that should be offered to our patient.
Thank you so much, madam, for summarizing the first case. Now coming to second case, Dr. Akash Gajjar, sir. A 21-year-old girl, unmarried, complaining of painless
Hello.
heavy vaginal bleeding. Yes, Dr.
Good
Naman, you want
evening.
to add something?
Yes, sir. Sir, I am currently practicing in a sickle cell belt, Dahod.
Very good.
But sir, I don't think that sickle cell patient never comes with a complaint of menorrhagia.
Right.
Means that hemophilia coagulation disorder might be the cause for in earlier lekin, but thalassemia and sickle cell anemia, I don't think that they come with the complaint of menorrhagia. Means since last 2 years I haven't seen. Yes, they complain.
They are compensated with the low platelets, sir.
Okay, sir. Lekin, but sir, means in those patients, I have seen that HPHS is not developed. So in spite that they come with a history of amenorrhea, as
But not
rather
menorrhagia.
rather than
you
menorrhea.
observed. Okay,
Yes,
sir.
sir.
Thank you so
Means.
much. Now coming to Dr. Akash, sir. A
Yes, sir.
20-year-old girl, unmarried, complaining of painless heavy vaginal bleeding. She also has irregular symptoms and hysterism. Dr. Mudita will come to you. UAG suggests you of bulky ovaries with increased volume. How you are going to proceed this? First, diagnosis, hormonal assays, and stepwise approach for this girl.
Yes, sir. Starting with the history, she is 21 years. The cycles are painless, heavy vaginal bleeding, and the cycles are irregular. So these cycles are anovulatory cycles mainly. So if we take the menstrual history, how many days of the cycle, duration of the cycle, pattern of the cycle, and second number is the here in the history part, there is a weight. What is the weight of a patient? And the BMI criteria is very important. She has mild hirsutism, so it points towards the polycystic ovary. And USG criteria also meet with the diagnosis of polycystic ovary because the bulky ovaries. So hormonal assay, so the diagnosis is clinical. Mainly first is the polycystic ovary. We can see the patient, we can see the clinical features, and we can have the history of menstrual cycle. So based on these two things, we can have the probable diagnosis of polycystic ovarian syndrome. And if we want to support our diagnosis, then we can go for the ultrasound examination. So the both ovarian volumes and multiple follicles and the size and all the criteria which meet with the polycystic ovarian syndrome. So this patient, as of hormonal evaluation, as far as the hormonal profile is concerned, then thyroid, that is a hypothyroid and hyperprolactinemia, it should be ruled out. Second number is FSH and LH, that is a baseline. Free testosterone, that is very important. If it is rises by 1%, then also it gives rise to significant cycle abnormalities. Sugar, there is a metabolic screening is very important in form of lipid profile and the fasting insulin glucose ratio and the DHES value. So these are the workup for the PCO cases, sir.
Very rightly said, ultrasound diagnosis is important, day 2 hormonal assays. And then what is a stepwise approach for treatment?
So if this patient is a obese PCO, then the weight loss is the first and foremost therapy or the counseling is to be done regarding the weight loss. 5 to 7% of the weight loss from the initial gives rise to the good cycle regularity. We have to counsel regarding the lifestyle modification in the form of the good diet, and probably we have to give the importance to the exercise for the weight loss. Second number, fat loss. That is a fat which is deposited in the abdomen area, thighs area. That fat loss, which is very important and which gives rise, cut down the excess of the estrogen in the body, and that may be the cause for the irregular anovulatory cycles, because it is unopposed estrogen that will give rise to the anovulatory cycles. And these pattern are also always related to unopposed estrogen because there is no ovulation. So a lifestyle change, that is the first and foremost thing to be advised to the patient. Then comes to the hormonal therapy in the form of pills, or patient is unmarried, so there is no planning for the pregnancy. So we can give her the hormonal therapy in the form of the pills or the good spironolactone derivative like drospirenone, which will not give rise to the much weight gain in this patient. and they always care for the other metabolic abnormalities in the form of if patient is having a dyslipidemia or a borderline diabetes type 2, then we have to control with the good calorie and the diet and exercise, sir.
Very rightly said, Dr. Akash. Now coming to Dr. Chintan, sir. Dr. Chintan Thakkar, sir.
Yes, sir.
How are you going to go about the diet for these girls, sir?
Sir, before giving answer to your question, I would just like to give a comment regarding this PCOS thing. Because right now we are living in an era that every second or third, this teenage girl or a 21-year girl would come to your OPD and say that, doctor, please check me whether I'm not having PCO. Because it has been so, popular amongst the social media and all that thing. So it's our prime duty sometimes to rule out rather than the diagnostic cases of PCO. So as per the PCOS society, out of these four things, uh, out of the four things, there which are the four criteria for PCOS, that is menstrual irregularity. The second is ultrasound appearance of polycystic ovaries. Third is the biochemical evidence of this increased LH and everything. And fourth is the hirsutism and other, skin appearances. Out of four, at least two criteria should be present to label her as a PCO. Otherwise, sometimes looking at the ovaries and we see multiple follicles and we diagnose her as PCO, the lifetime she will live with that tag of PCO, in spite of that could be an occasional finding. So just a word of caution, before labeling any patient as a PCO.
I think Dr. Chintan has got a very valid point, Dr. Kalyan sir, because what happens, we cannot prescribe any test randomly.
You are come to a diagnosis. So you are come to a diagnosis of PCOS, and so many OPD patients tell you about the PCOS story. Now, how are you going to do counseling for this patient for diet, sir?
Sir, that regarding that question,
Chintan, sir, diet.
Yes, sir. Yes, sir. See, first of all, if I have a luxury of dietitian available to me, I would straight away tell her to meet my dietitian and counsel her regarding that. Suppose I'm practicing in an area where dietitians are not frequently available, so we tell them that your diet should be more less in carbohydrate and sugars, more in protein, and more in fibers. And accordingly, whatever her profile is, we can ask her to take more of the raw salads, the oats, and the high fiber diet, as well as cut down on the junk food, fast food, sweets, and fried foods. More of liquids and more of water, and cut down, of course, the calorie intake also. So we had trained, our medical officers to counsel regarding the specific diet for weight loss as well as these PCO patients. And we see to it that they actually understand the value of all the three things, that is diet, exercise, and medicines together. So that has to be a spiritual approach.
Few words about exercise, sir.
Yes, sir. Again, she has to work out at least to me 35 to 40 minutes a day, at least 4 days a week. And that has to be it has to be a combination of strength exercise as well as aerobic activity. And rather than going for an over optimistic target, we should we should try to convince her for realistic targets, like she can target to lose weight of to the extent of 10% in 3 months or so, uh, or at least 3 to 5% in 1 or 2
0.5
months.
kg a week. Yeah, 2 kg or 3 kg maximum per month is recommended for, right?
Correct, sir.
Sir, one point I would like to add in PCO.
Hello?
Psychological. Hello,
Dr.
sir.
Mudita?
Dr. Akash here.
Yes. So, Dr. Akash.
Sir, one point I would like to add. One point I would like to add. Psychological counseling to boost up their moral regarding their appearance, regarding their weight, and
Very
regarding
right.
their cosmetic look, overall look. that is very important to boost up their confidence that they can reduce the weight, they can normalize their cycles, and later on they can become fit like other persons. Because to reduce the weight, it demands lots of mental strength rather than physical strength.
And
So
self-esteem is very important in these girls.
yes, because
Uh,
with very heavy weight, obesity, their self-esteem is low. That's why we
Right.
have to boost up. Yeah.
Dr. Akash, now you have come to a diet, exercise, diagnosis of these patients. They are like a PCOS. What is the medical management for these girls? These girls specifically.
Sir, hyperinsulinemia and the hyperandrogenism, they go hand in hand. So hyperinsulinemia is there, maybe insulin resistance. So we have to reduce the insulin resistance. We can reduce the androgen production with the help of the contraceptive pills. There is a combined oral contraceptive pills. They decreases the FSH and LH both because the ratio is altered in such type of the cases. So we can give them the combined contraceptive pills, and these pills they decrease the insulin resistance, decrease LH, decrease FSH, and later on they decrease the circulating level of free androgen, and that will increase the SHBG hormone, SHBG from the liver also. So that will overall help in correction of these hormonal abnormalities in such type of the patients.
Very rightly said. And she might require a help of cosmetologist or skin
Cosmetology,
specialist for
yes.
them.
Unwanted hair removal.
Dr. Akash, do you recommend to start metformin in low doses for these girls?
Yes, sir. In metformin is very effective in obese patient with borderline type 2 diabetes mellitus or borderline metabolic syndrome or hyperinsulinemia. So metformin helps in reducing the metabolic disorder, also helps in reducing the weight of the patient.
Okay, so the blackness around the nape of neck,
Yeah,
acanthosis nigrans, these are the
yeah,
signs where you need to diagnose insulin resistance, and you can start with the oral contraceptive with metformin.
metformin, yes, sir.
Any other drugs you are using? Some herbal preparations or something these medical representatives eat your head day in and day out?
Sir, there is a one syrup is available, M2 tone syrup is available. I have seen them using in the south when I was at Bangalore. They were using one of the leading center of
Cycloset, M2-tone, Menthol,
cyclocet,
these
yeah,
are the
M2
drugs
tone
which are
syrup.
available, but they
Yeah,
don't have any clinical studies as
clinical
per my
no
knowledge.
study. Yes.
Yeah, Dr. Mahesh Gupta sir is there. Again, I'm asking for my expert, Dr. Mahesh Gupta sir. Dr. Monica, can you just call Dr. Mahesh Gupta sir so that he can be there to answer some of the doubts? Now coming to Dr. Archana Dwivedi, to just summarize about the case 2, that is PCOS patient with AUB.
Yeah, I think this is a very, very PCOS is with everybody nowadays who comes in the OPD, thanks to Google Baba, and ladies are already fed. A lady
And
will
Dr.
come with a
Chintan
10-year girl also.
About the myths
Yeah.
of PCOS. Dr.
Yes.
Chintan, thank you so much. Yeah.
So I would just like to say that PCOS is a lifestyle disease. It is a diagnosis of exclusion. Please diagnose your patient with the lab investigations on day 2 or day 3, empty stomach. Do a sonography scan on day 5 to 7, not randomly, to rule out multifollicular, wrongly named as PCOS, first of all. And lifestyle modification, as you rightly pointed out, 80% is your diet and 20% is your active lifestyle. So that is important, and young girls need to be psychologically reinforced, very well highlighted by Dr. Akash and teammates. And yes, metformin is there to stay. We have to supplement OCPs for a period of say 3 to 6 months, but we have to reinforce them lifestyle modifications so much that they don't need their oral contraceptives later on, because even 0.5% of 5% of weight gain or the abdominal girth increase by just 1 inch is going to help them with their menstrual irregularities. So I think this is PCOS is something, the era disease, and it has to be there and has to be considered very, very judiciously before prescribing any XYZ things available in the market. Only what goes by the study should be given to our patients, and never label them prematurely. Thank you so much.
Thank you, Dr. Archana Madam, for rightly telling about the actual management of AUB in a case of PCOD. Now, coming to Dr. Mudita, Madam. Dr. Mudita is there? Dr. Mudita. Dr. Devraj has joined? No. So coming to Dr. Naman Agrawal, case number 3, 31-year-old lady, para 2, living to with history of IUCD insertion 3 months back. She complains of irregular bleeding and wants to remove IUD. What should be the line of treatment? Dr. Naman.
Hello. Good evening, sir.
Good evening, Naman.
Sir, any patient who has we have applied IUCD and is coming with problem of AUB or discharge. So the first should be the conservative management. We should go with the antibiotics and tranexamic acid, and then we can continue this treatment. If patient does not get any relief, then we can think of removing the IUCD.
So, Dr. Akash. Dr. Akash is there?
Yes, sir. Yes, sir. Yes, sir.
Dr. Akash, every time a patient comes to you, like an LNG IUS or IUD, this patient will always complain of irregular bleeding, spotting, intermenstrual. How are you going to differentiate the counseling for a simple IUD and with LNG IUS?
A simple IUCD, the placement of the IUCD that we have to confirm first by ultrasound. That is first thing. Second number is such type of the patient where they have the history of irregular bleeding and they want to remove their IUCD, then pregnancy is ideally to be ruled out, because pregnancy can occur if there is a misplaced or displaced IUD is there. Regarding the hormonal IUCD, there is LNG IUD is concerned. It induces the atrophic changes in the endometrium. So atrophic changes which is responsible for sometimes irregular spotting or bleeding in such type of the patients. So we can counsel them regarding if such type of irregular spotting or occasional spotting can occur before permanent amenorrhea.
Very rightly said. These are the patients where you need to give your personal assistant number so that a proper counseling for LNG IVS, because this patient might have trouble for 3 to 6 months, and once they get used to it, then there are hardly any issues and they are better to improve the quality of life for these patients. So directly removing IUD, you need to just rethink about it. Now coming to Dr. Dr. Deepika Singhvi, madam, case number 4, 44-year-old lady, para 3, living 3, all vaginal deliveries. Last delivery 8 years back, complaining of menorrhagia since 5 to 6 months. Cycles are irregular, 45 days to 60 days since 6 months. On examination, uterus is bulky, that means 6 to 8 weeks. What is the differential diagnosis and what is the history and investigation, and how are you going to manage this patient? Dr. Deepika is there?
Yes, sir. Yes, sir.
Yes, Dr. Deepika, ma'am.
Yes. So as you told, it's a 44 years of age with irregular bleeding of previous with the preceded history of amenorrhea followed by heavy bleeding. So chances are that it could be an anovulatory bleeding. Second, as you told, it's uterus is bulky, 6 to 8 weeks. So possibility of adenomyosis also can be there. In this case, of course, first, after a thorough examination, I would like to do a one proper transvaginal sonography, which helps me to rule out whether it's endometrial hyperplasia is there or not, because it's an anovulatory bleeding. So chances are there that it could be a thick endometrium. And is it a symptomatic adenomyosis could be there. So if it is on sonography, if I found it's a thick endometrium, I'll advise her for endometrial biopsy to rule out the exact histology of endometrium, and accordingly we can prescribe her the medicines. I'd like to give her a trial of first treatment, which is a progesterone, high dose progesterone. I will start with the norethisterone or MPA we can use the 30 milligram per day, and accordingly we can taper down depending upon the response of the patient.
Okay, you are going to do an endometrial biopsy for this by PIPEL, maybe OPD procedure, and it comes out to be an endometrial hyperplasia. How are you going to manage differentiate?
So whether it is a atypical or non-atypical, I have to rule out. So biopsy helps me to rule out that. And if it is a endometrial hyperplasia, I'll give you her a long-term progesterone for 3 months.
No, if it is without a TPR, then you can manage with the medroxyprogesterone or LNG-IUS. But with a TPR, then what is your management, how it differs?
So if it is with ATPR, then there is a high chances of risk of malignancy is there. So I'll advise her for surgical management.
With a hysterectomy if she has finished the family, right?
Yes, her family history is already there.
Okay, thank you. Dr. Akash Gajar, coming to you again. What is the role of LNG-IUS in these cases and selection criteria? Are there any contraindications?
There should not be any organic pathology. That is
Right.
first we have to rule out, because like
But
the fibroids.
nowadays they say fibroids less than 2 centimeter, you can still
We
put.
can use.
But submucous myoma we cannot use
So
LNG.
irregular cavity, too large a cavity, then
irregular
it is
cavity too
contraindicated.
large. Yes. So if it is a symmetrically enlarged uterus, 8-week size, 10-week size, and there is no organic pathology, then we can go for the LNG IUD in such type of the patient after ruling out with endometrial biopsy. That is to be done first. Then second point is we can give her the pills or LNG IUD. Because before giving the LNG IUD, ideally histoscopy or DNC biopsy, that is at least OPD based procedure, and the biopsy, if it is normal, then we can go for the LNG IUD.
So what are the indications of hysteroscopy in AUB?
If the USG is suggestive of irregular cavity, endometrial hyperplasia, or if there is any polyp is there, then or submucous myoma is there on ultrasound, then we can diagnose and we can have the biopsy of proper that site only. So a biopsy, if blindly we can do if the biopsy like simple DNC, then sometimes the target area we miss. Of hysteroscopy guided biopsy, then we do, then the probable target area, we can take the biopsy from the target area and we can diagnose the earliest possible malignancy if it is there.
Yeah, with PIPL, you cannot remove a polyp. Anytime there is a polyp or some fibroid, you can't. So these are the cases where you can do a diagnostic as well as therapeutic hysteroscopy in these patients. The treatment options are medical first, most probably with the invent of LNG-IUS, that is a first-line drug nowadays, that is putting a LNG-IUS, or you can give progestins either cyclically or you can give withdrawal also. And or continuous, and surgical is polypectomy, myomectomy, whichever is required depending on the palm coin classification. So Dr. Chintan Thakkar, sir, what are the treatment options for abnormal uterine bleeding depending on the palm coin etiology, sir?
Yes, sir. Palm coin classification itself has been made with an intention to guide us regarding the treatment option also. So regarding the previous discussion, I would just like to add that, after the diagnosis, we have done everything, hysteroscopy, 3D sonography and endometrial biopsy. If we are planning to preserve the uterus and do a conservative management, maybe in the form of medical LNG or some DNC, like that. Before doing that, I would just like to do a pap smear, that is by liquid-based cytology, so that I'm very sure that I'm not dealing with any. I'm not keeping this uterus with a cervical pathology.
Right. So you are going to rule out CIN.
CIN or other high grade.
Because otherwise, while doing an endometrial biopsy, if there is an abnormal cervix, which will be very well taken up by the gynecologist. Yeah.
Sure, sir. So regarding that palm coin, according to that, if I get a polyp, and there is no other pathology, I would simply go for a hysteroscopic polypectomy with the histological diagnosis of that polyp to rule out malignancy.
So there are eight polyps now inside. You have put a hysteroscope. There are 8 to 9 polyps.
Sir, I would like to remove them all.
All?
Yes, sir. No matter how many polyps are there, and I would definitely like to subject every material which I have extracted from the uterus.
So if there are 8 to 9 polyps, what I believe is just take a biopsy of one polyp and put a LNG-IUS. What do you feel about this? Or any suspicious polyp you are thinking of suspicion in one of the polyps, then it's right to remove all 8 to 9 polyps. That is my view as a hysteroscopist.
Yes, sir, I respect your view, but actually, I would not, because going back, going outside the OT and telling that I had seen 8 of the polyps and I have removed one just for biopsy, the rest of the being taken care by LNG.
Okay,
I
okay.
would, it
Dr.
would be
Chintan, then
slightly
again,
difficult
here
for
is the
me.
contradiction. You are going
Yes.
to remove all the polyps by scissors, or are you going to use something else?
Yes, sir. I usually prefer cold scissors for the polypectomy
Sir,
only.
रात्र
Yes,
What's
Dr.
your
Mahesh,
question?
sir. There are multiple polyps.
No, रात्र Hello.
Mahesh, sir, there are multiple polyps, 8 to 9 polyps.
Yes.
So are you going to remove all the polyps, or my discussion is remove one polyp and keep a LNG IUS? Or
What is the
second option is remove all polyps by cold scissor. Third option is remove one polyp, send for histopathology, use a manual vacuum aspiration and remove all the polyps with the MVA cannula. What is your view about this?
what is the age of the patient?
45 years.
Yeah, 45 years. So basically, if I am going for a polypectomy, then on the same sitting, I would like to remove all the polyps
Okay.
and then follow up.
Okay, right. Because she was not concerned about the fertility, I was thinking of
Yes.
putting a LNG IUS.
Yeah, so preferably if it's possible, I'll remove all the polyps, and all the time it is not necessary to use a hysteroscopy scissor. With with good this
Sectoscope.
small swab holder, we can remove the polyp. Even fibroid polyps also we are removing with the swab holder. With just the hysteroscopy scissor, we cut the capsule and then we take out the polyp, fibroid polyp with a swab holder. So we have a small tips swab holder, and we routinely use for removing of the products of conception and the polyps and the fibroid polyps. But I'll remove all the polyps.
Okay, coming back to Dr. Chintan, sir.
Yes, sir.
So polyp, okay, there is a dilemma always, because I was thinking that she's not, she has finished her family, LNG IUS can do the same. That's fine, we can remove all the polyps. Adenomyosis.
Right, sir. Sir, regarding adenomyosis, I would slightly think of whether she wants to conserve her uterus, and regarding the size of the uterus, regarding the size, the percentage
She's
size
now
of
6 weeks.
6 week size of the uterus.
6 to 8 weeks, according to the history.
Right, sir. So if this much size, and if her symptoms are not a lot, the menorrhagia is not a lot, and she's willing to preserve her uterus, then probably I'll go for LNG IUD.
Okay, sir. Good. That's good. And what about the surgery option, Dr. Thakkar, sir?
Again, sir, I would ask her, her willingness,
her opinion about
whether
the preserving
preserve the uterus or not. If
now
she is not
my
very
dilemma is again to you. There are multiple fibroids. She's 45 years and wants to preserve the uterus. So what are you going to do about the AUBL?
Okay. Sir, according to the literature and according to me also, these are the submucous variety of fibroids which are more responsible for her menorrhagia problem. So if she is willing to preserve the uterus, yes, and there are submucous fibroids, my first target would be this, to remove either hysteroscopically or laparoscopically.
Very rightly said. I like the approach Dr. Chintan Thakkar is thinking. Every time a patient comes to you at 45, just don't think of knocking off the uterus. He's just talking to the patient, doing a counseling about preserving the uterus, which is very important, because we are the only gynecologists who know the importance of the uterus. If she goes to a surgeon, he's going to remove it. So very rightly said by Dr. Chintan sir, that you need to do a counseling, take a proper consent, and do as far as possible conservative treatment like removing a polyp, removing adenoma, putting an LNG IUS, doing a lap myomectomy or submucous myomectomy. Now coming to AUB-YUM, there is no options
Dr.
for you now.
Kalyan, may I interrupt?
Yeah, yes, sir. Just 2 minutes, sir. He'll finish the case. Then, as an expert, you need to talk about the whole case. Sir. Just 2 minutes, sir.
Yeah,
Yes,
yeah,
Dr.
sure.
Chintan. Yeah.
Yes, sir. Then comes the M part, that is endometrial hyperplasia and malignancies. If this, if there is an atypia in the your DNC histopathology report, or it's a full-blown malignancy, I think PLH BSO would be the only option. And if there is an endometrial hyperplasia proved on pathological report, then okay, the surgery as per the requirement of malignancy. I think in that part, endometrial hyperplasia part or and malignancy part, I would not think of conserving the uterus.
Very rightly said. Because AUBM, you need to operate. Here you want to know whether to do the pelvic lymph node, bilateral pelvic lymph node dissection or not, depending on the type, whether it's a only hyperplasia or it's a malignancy proven. Right, sir?
True, sir. Right. Very right.
Yes, very rightly said. So there is a definitive role of LNG IUS for this patient, which has been proven beyond doubt that it is effective in reducing menstrual blood loss as well as other symptoms associated with idiopathic menorrhagia. And these are studies which are done by all international papers. Now coming to Dr. Mahesh Gupta, sir. This lady is 45-year-old. Her uterus size is 6 to 8 weeks. Endometrial sampling done. What is the expert's opinion about a lady 45-year, para 2 living 2, tubectomy done, and uterus size is 6 weeks? Dr. Mahesh, sir. Dr. Gupta, sir.
Her basic complaints are menorrhagia and dysmenorrhea,
Yes, sir.
or
Menorrhagia since 6 to 8 months.
yeah. So if the endometrial biopsy turns out to be normal, then this patient is a candidate for the non-surgical approach. And for
Yes.
this non-surgical approach, we have this LNG IUG is a most appropriate for this case.
Yes, sir. Thank you.
So,
And you wanted to add something about the last
yes, that
AUB?
Chintan was talking about what you were talking about, the multiple fibroids.
Right, sir.
And Chintan was talking about the conserving the uterus, either doing by hysteroscopy or laparoscopy. So here, just I have some different opinion that when you are going for a surgical approach, then I think it should be a definitive surgery.
No. Dr. Chintan sir was talking about the submucosal fibroid. He said you have to remove it. If they are subserosal, then they won't cause menorrhagia, so no need of removing it. Any other opinion about this, sir?
Yeah, then also that's what I'm saying you, that if it is a submucous fibroid and it is bleeding, then that it is a different thing. But you are talking about the multiple fibroids, and just patient wants to conserve the uterus, then you are going for laparoscopy or hysteroscopy. So then I feel that when you are going for a surgical approach, then it should be a definitive surgery. Otherwise, we have plenty of non-surgical approaches like what I have told about this LNG IUG, or you can have a leprolide depot also that can also cure the
Yes, we need to
menorrhagia.
counsel the patient properly about the surgical options. You need to talk about the
And third
uterus
thing,
removal, ovary preservation. Yes, sir.
Yeah, and third thing is at present there is a much hue and cry about this elagolix and relugolix. I don't know what is how far it is effective in the adenomyosis or in cases of menorrhagia with bulky uterus.
Yes, sir. Mahesh, sir, we have not touched that part because it is really new. There are so
Yeah,
many
so-
marketing strategies going on. So we have not touched that component. We are just discussing about the proven things about all the guidelines, sir. Yes, sir.
Yes.
Very rightly
Yes,
said
sir.
by you, because these
One
are the
thing,
new
sir,
drugs which may work or may not work, right?
So just
one thing,
one
sir,
example, which I had a live case regarding this. Recently, I had a 42-year-old patient from Canada. He was known to me. He already had one child, 42 years with multiple fibroids, and including submucous and all intramural subserous varieties also. Total, she had more than 6 fibroids. I don't remember the count right now. We did counsel her regarding the hysterectomy since already she had one child. But then she thought that I may think of a child, having a child still after 6 months or 1 year. And I don't want a hysterectomy. So in this case, practically, we had to do a combination of hysteroscopic myomectomy as well as laparoscopic myomectomy. and we had to remove
See,
all the fibroids. Yes, we did
Chintan,
something that.
Chintan, this patient anyway goes for the IVF, no, at the 45 years of age if she wants to conceive,
Correct, sir.
right?
Yes,
Uh,
So the IVF people, they don't find any contraindication for anything.
yes, Dr.
And
Mahesh sir,
and
We
and
want,
later,
we
we
want,
need to do a
we,
proper counseling.
we want presence of uterus only.
yes. So if that patient will come to me for cesarean section, I can remove the baby and I can remove all the fibroid at a one sitting. So the
Right.
single surgery will be needed.
So Dr. Chintan needs to do a proper IVF and send to you for delivery. Thank you so much, sir. Yeah. Now coming to the last case, this is a case where we want to discuss, and coming to Dr. Mudita has joined. 60-year-old lady, para 2 living to, postmenopausal since 10 years, known case of diabetes, hypertension since 6 years, history of postmenopausal bleeding, first episode. How you are going to proceed, and wait and watch or directly evaluation and investigation? Coming to Dr. again, Akash Gajjar, sir.
Yes, sir. She is 60 years with postmenopausal since 10 years, and recently she has a bleeding first episode. So each and every case of postmenopausal bleeding PV, the first episode or maybe the many episodes is to be evaluated thoroughly. Second
Very
number,
rightly said.
age is independent risk factor for any carcinoma, that is carcinoma endometrium or CS cervix. Diabetes and the hypertension are again risk factor in this patient. So any case of postmenopausal bleeding PV, ideally the first part, that is a history taking, that how many days of the period was there, and after 10 years she has got this first time of the episode, it was spotting PV or proper bleeding PV is there. Local examination at the cervix, that PS examination for any cervical pathology. Transvaginal ultrasound, most of the time we get the uterus that is atrophic size, and sometimes the atrophic endometrium is the cause for this bleeding PV in this type of the patient. Plain DNC is ideally not useful. Always go with the hysteroscopy and DNC or hysteroscopy guided biopsy with histopathological examination. And
Gold
if we
standard.
suspect
That is a gold standard. Yeah, right.
gold standard, and if at all we suspect any cervical pathology, then there is a role of colposcopy guided biopsy that is must. And always go look for the adnexa in this type of patient. Sometimes patient may have simple ovarian cyst also in such type of the patient also. That may
Very
go
rightly said,
on
Dr. Akash, sir. Now you do a biopsy by pipel in this case, or hysteroscopy is
ideally, sir,
the
hysteroscopy.
approach?
Ideally, I will go with hysteroscopy guided biopsy.
Yes,
That
sir.
is
Very
the gold
rightly said.
standard, sir.
Right. TVS has go role. What is the endometrial thickness you are looking, Dr. Akash?
Less than 5 millimeter ideally.
Okay, more
Or
than
up to-
4
up to
millimeter,
7
you are going to suspect.
Up to more than 7 millimeter, then it is suspected. Less
Okay,
than 4
so
millimeter,
many
ideally it
times.
is.
Yes, sir. Very
Ideally, it
rightly.
is to be 4 millimeter.
Yes.
Ideally.
Yeah. So Akash sir has said about endometrial thickness less than 4 millimeter, endometrial sampling done, symptoms persist, this patient's negative evaluation, then you can do a hysteroscopy directed biopsy. But it is more than 4 millimeter, you need to do a office endometrial hysteroscopy biopsy. That is a gold standard for this patient. Endometrial biopsy is required if endometrial thickness is more than 4. Endometrium shows diffuse or focal increased echogenicity. Endometrium is not adequately visualized, and women has persistent bleeding.
And
So
in
this can.
ultrasound, if we see the irregular endometrium,
Right.
that is at the level of endomyometrial junction, and if we see the echogenicity of the endometrium is irregular and pattern is irregular, then it is suspective of the malignancy.
For biopsy, less than 4 millimeter pipel, tau brush, that can be used. For others, hysteroscopy is the gold standard because it is immediate evaluation, visualization of the lesion. Even you can see the endocervix, that is very important. And the management is once malignancy is excluded. Dr. Akash?
Yes, sir. First is malignancy has to be excluded. We can reassure the patient that this type of the episode can occur. But if at all we found there is hyperplasia, atypia, or without atypia, proliferative irregular endometrium in this type of the patient with associated risk factors, then ideally patient has to undergo the hysterectomy. That is the last option.
Right. And lastly, about atrophic changes, local estrogen therapy.
Local,
And
yeah.
sometimes I have seen patient with pessary
Forgotten pastry,
rheumatoid
yeah.
with the
Forgotten
blood
pastry,
ignore.
yeah. Yeah.
Yes,
Sir,
sir.
can I add to this?
Yes, sir. Dr.
Actually,
Chintan, sir,
my
please.
my approach to the postmenopausal patient who is having bleeding since 10 years postmenopausal, even if the biopsy, endometrial biopsy comes out to be negative, I would still like to counsel her for hysterectomy. Since
Yes.
I have come across, the literature also that there is very high chances of, false negative histopathological report in DNC and actual endometrial malignancy. So probably I don't want her to come back after some time with the malignancy part. And as such, at the age of 60 years, I would still go for counsel her at least for hysterectomy, even if the biopsy is negative.
Okay, if biopsy is negative, you can do a second opinion, but preserve the uterus as far as possible. That is my view, sir.
Okay,
Dr.
sir.
Chintan, sir, so sorry for this.
No, sir. I respect your view. In fact, I'm just
Because
slightly.
I was the one who started the Save the Uterus mission, then Preserve the Uterus mission, and there were unnecessary hysterectomies going on in some part of the Maharashtra. So Foxy has intervened, and now we have trained more than 40,000 gynecologists about the preserving the uterus and non-surgical approaches for AUB. So take-home message is common problem from menarche to menopause. Current revision of the 2 FIGO AUB system to improve the utility of this system for research, education, and clinical care. Newer drugs are promising. Evidence-based management can avoid number of unnecessary hysterectomies. Treatment should be individualized, encompassing impact of pressure symptom, desire of retention of fertility, contraceptive needs, and impact of symptoms on quality of life. The incidence of postmenopausal bleeding is 10%. Patients with postmenopausal bleeding have 10 to 15% of chance of endometrial carcinoma. If bleeding is present on continuous combined regimes after first 6 months or once amenorrhea is established, consider as abnormal and evaluate. ACOG cutoff for endometrial thickness in postmenopausal bleeding is 4 mm. Every woman with VMB should be assumed to have a carcinoma until full investigation has proved to the contrary. So I am really thankful to my both experts, Dr. Archana Dwivedi, Dr. Mahesh Gupta sir, and wonderful discussion by Dr. Chintan Thakkar sir, Dr. Akash Gajjar sir, and Dr. Archana Dwivedi madam, Dr. Mudita Madan, Dr. Naman Agrawal, and Dr. Deepika Singhvi for this, and Dr. Akash Gajjar for interactive session about AUB panel discussion. I'm thankful to Dr. Monica Gupta, Dr. Monica Ambardhan for giving me 1.5 hours today for the panel because somebody is missing, and whether she's joining, Dr. Monica?
Yeah, she's there.
Right.
Yeah, join.
Yes.
Yes. So I thank everyone, all the panelists. So now coming to two people, Dr. Chintan and Dr. Akash, one word of wisdom for listeners for AUB in young girls.
Puberty menorrhagia, that is the first in patient that is to be thoroughly evaluated, mostly focusing on the coagulopathy or underlying bleeding disorder. That is first. Reassurance and non-hormonal treatment majority time work in such type of the patient. And any case of a menopause, that is a post-menopausal bleeding PV, is to be thoroughly evaluated in the form of USG as well as histoscopy guided biopsy. And if we can counsel her the patient, then if all the investigations are negative and ruled out malignancy, then we can go with the conservative management in this
Thank
type
you,
of
Dr.
patient
Akash.
also.
Dr. Chintan, sir, AUB in case age from 20 to 45. Dr. Chintan Thakkar, sir.
Yes, sir. Only two things. First of all,
AUB from 20 to 45.
Okay. First of all, a per speculum examination is a must because we live in an era that everyone is very much conversant with ultrasonography, hysteroscopy, and all high-tech things. But the part sometimes which is being ignored is per speculum and PV examination. So it's must in all cases of AUB. And second, we should be very conservative in diagnosing any case or labeling any case with PCO. Only with strict criteria we should label it.
Thank you, all my panelists, for wonderful discussion. Over to Dr. Monica, madam.
Thank you,
Dr.
sir.
Archana ji, thank you. Dr. Mahesh ji, thank you. Dr. Archana, madam, you want to conclude?
Yeah, no, I don't want to conclude. I want to congratulate Dr. Kalyan. It was a very nice session and all the best wishes for your future endeavors. We are seeing good future for you. Thank you so much.
Thank you, Dr. Archana ji. Dr. Mahesh, sir. Okay, he's busy.
Thank
So,
you.
Dr. Yes, sir.
Thank
Sir
you.
is
Mahesh,
there,
sir,
sir is
any
there.
words of wisdom in case of AUB?
I'm not that wise to give you wisdom, but
Pearls of wisdom.
yeah, but in see, many our WhatsApp group, we are daily seeing that people are putting their hysterectomized specimen. So when we are coming for the discussion of the AUB and AUB and this hysterectomy, so there is we see the gross contradiction in that specimen. There are small menopausal size of the uterus. Everybody is removing and they are posting on the WhatsApp.
Lemon size uterus.
Yeah, so today I did this much hysterectomy. Today I did this number of hysterectomy. So although everyone has some kind of stress, but as far as the hysterectomy or surgery is to be offered, then it is to be offered very rationally. That
Very
is a
rightly
word of
said.
it.
Dr.
Yeah.
Mahesh, sir, is rightly saying about the preserving the uterus. Don't do any unnecessary hysterectomies. Don't fall into that trap because somebody is watching you medico-legally also. Thank you, sir, for your words of wisdom. Over to Dr.
Thank you.
Monica Gupta.
Thank
Dr.
you. All
Part,
the
are
best.
you there? Dr. Part Shah, you want to say something? Because we have called him as a chairperson and
Oh,
Dr.
so sorry. Dr.
Ah,
Parth, are you there?
I think he has gone for an emergency cesarean. He has texted me. So I thought he would have come back to.
No, Dr. Monica, you carry on. Thank you.
Thank you, everyone. Thank you,
Thank you,
Alpesh
everyone.
sir, for being chief guest. MC Patel sir and Parul sir for the guest of honor. Our experts, Mahesh sir and Archana madam, and all our panelists and moderator, Dr. Kalyan sir and Monica Umardan for giving this opportunity and for joining and making this webinar successful. In last, I just want to say Dr. Kalyan sir is going for the vice president election this year. Please nominate him, though right now he is unopposed, but you can never know कि whenever we need your support, you should be there for us. Thank you very much.
Thank you, the tech team of Corona, for giving us this academic platform. And thank you, Kalyan sir, for entrusting me and Dr. Monica madam with this job. Thank you,
Thank you,
everyone, for
sir.
joining
Thank
us
you.
today.
Good night.
Thank you, madam.
Good night.